coronavirus with varying presentations. Dilemma in management has always been an issue during all the waves of pandemic. Now, not only in India, but all over the world. On behalf of IMA Gwalior, I welcome today's speakers, Senior Consultant and Director of Internal Medicine of Medanta Medicity, Dr. Sushila Kataria. She's a very well-known figure. I welcome you, Dr. Sushila.
Thank you, ma'am.
Then the other star speaker is Dr. Dhiren Gupta. He's Senior Consultant, Department of Paediatrics in Sir Gangaram Hospital. I welcome Dr. Dhiren. Both of them have been serving COVID patients during pandemic since beginning, and today we are going to learn from their experience. IMA Gwalior welcomes our very own Dr. Alok Gupta from United Kingdom. He's a director and senior consultant and diabetologist in NHS UK. We will be certainly benefited by his experience and his presentation on the subject. We welcome Dr. Ajay Gaur. He's one of today's panelists, HOD Pediatrics, Gwalior, KRH Hospital. Dr. Ravi Shankar Dalmia, he is eminent cardiologist in Gwalior. Dr. Nilima Tandon, HOD Anesthesia, Super Specialty Hospital, Gwalior. Dr. Manish Sharma, Senior Consultant, Associate Professor of Medicine in JA Hospital. Dr. Manish Gupta, Senior Nephrologist in Gwalior. Dr. Anupam Thakur and Dr. Ujjwal Sharma, they are experienced pulmonologists in Gwalior. Dr. Urmil Tripathi, she is President of Ops Gynae Society of Gwalior. Dr. Ravindra Bansal, he is Senior ENT Surgeon. I welcome all the panelists, and I welcome today's moderators, Dr. Abid Salim. He is Consultant, Emergency Medicine and Critical Care, RJ Apollo Spectra Hospitals, and Dr. Parendra Bhasin, he is Director of the Ratan Jyoti Group of the hospitals. I welcome all the present and past officials of IMA Gwalior and Estate, and all the members and doctors you are joining today from different parts of India. And now I hand over to the moderators to start the session. Thank you.
Thank you, Dr. Premada. And at the outset, I would like to thank IMA Gwalior for giving this responsibility to us to moderate the session. And I request our very learned speaker and eminent speaker, Dr. Sushila Kataria. Please, you can share your screen, ma'am. Dr. Sushila Kataria is a Senior Director of Internal Medicine at Medanta Medicity Hospitals, New Delhi. And she has specialized in infectious diseases like HIV, dengue, COVID-19, and she specializes in multi-system disorders, lifestyle diseases, and adult vaccinations. And she has a special insight in COVID-19 management, and she has worked for last this is the third wave she is managing. I welcome you, and please, Madam Dr. Sushila Kataria.
Thank you very much. At the outset, I'd like to thank IMA Gwalior, especially Premada ma'am and Dr. Bhasin for giving me this opportunity. And we mutually learn. This is one pandemic whereas nobody has more or less experience. All of us are on similar grounds. So I will speak something and then we mutually learn from each other. Is my screen visible? Thank you very much. Okay.
Yes, it is visible.
So COVID-19 management in adults. This is my own institute protocol, which I will be sharing with you. And this is aligned with most of the national and international guidelines in management of COVID-19 in adults. And the dynamics of the disease are changing so fast that in the last near about just 2 months short of 2 years, we have modified our management protocol 5 times. So this is the final version which we have right now, keeping mainly Omnicron in mind. So first and foremost, what is different and what is not different, that the whole problem is that the number of cases are increasing at too fast a pace. Just to give you a perspective, on 3rd April, last Monday, from the place where I belong, which is just in the outskirts of Delhi, the number of cases were less than 100. It was actually 80 cases. And today we have reported 3,000 cases. So this is the pace of increase of these cases. Secondly, problem, we can't say that all of them are Omicron or how much is Omicron, because the genetic sequencing usually lags behind. So we have to go more clinically. At my institute, we do have some facilities to do a mutation testing to preliminary find out whether it is Omicron or not. But my understanding is that at least 70% of the cases which are coming are Omicron. There is a little difference in management of Omicron and non-Omicron. So it's important if we could have a mutation testing or genetic sequencing so that treatment can be aligned. First and foremost, when we are managing COVID-19, the first step is to assess what is the severity of the disease and to decide the site of treatment. To begin with, most of the cases are severe only, but it is not necessary that the cases will report to you in the beginning. So the case can report at any time. You divide cases into group 1, 2, 3. The group 1 is totally asymptomatic, milder ones where you have upper respiratory symptoms without any desaturation. Majorly, the oxygen saturation is 95 or above. Moderate are those who have upper as well as lower respiratory symptoms with mild respiratory distress with increase in respiratory rate from 15 to 20, between 15 to 24, and oxygen saturation between 90 to 94. These are the patients who need hospitalization into a ward. The first category can be managed in home isolation, and we encourage people to stay in home isolation if they're mild, because this will reduce the burden on the healthcare services. The third group is a severe disease patients or severe as well as critical patients where the oxygen saturation is less than 90 on room air, respiratory rate is 24 or more, there is evidence of acute respiratory distress syndrome, and there are unstable hemodynamics. These patients would need to be admitted into an intensive care unit. So once we go to this, then is the indication that how much investigation should be done in a just reconfirming,
please
am I
mute
audible?
your microphone. Everybody else should please mute their microphones. I request.
So depending upon the severity of the cases, we advise then in asymptomatic and mildly symptomatic patients without any risk factors, no lab investigations routinely are required. You would see a lot of patients would ask on the day one whether CRP, D-dimer, IL-6 or HRCT is required or not. And people are very proactive and they would actually come to you with a diagnosis and a CT film and all this. So it does not change the treatment actually. The initial investigations will not decide your line of management. So if there are no risk factors throughout the course of illness, we do not advise, at least I do not advise any routine testing until unless clinically the patient is having some other morbid illness and things it is required. In the patients with mild disease and risk factors, the risk factors I'll enumerate later on, we do a CBC or a hemogram and a CRP on day 3 to 5, and it is repeated if it is required to be, especially if the patient is febrile after day 7 of illness, or if they develop any desaturation, increasing cough or shortness of breath. In moderate cases, which are the cases which are admitted with us in the wards, we do a little more detailed workup because these are the patients who may require immune modulation, steroids and other things. So these are the patients where we would do a little more extensive workup, and we repeat the test on every 3 days or less often or more often, depending upon the case, the clinical situation, whether the patient is improving or deteriorating. Our ICU team does some additional tests in the severe cases where they do a pro-BNP, APTT, PT, echocardiography, etc. And some tests are repeated on a daily basis. Others are repeated as and when required. So typically for us, what we consider is a high risk is what internationally is known, any patient who's above the age of 65 years, whether comorbidity or not, only age above 65 years, chronic kidney disease, pregnancy, diabetes, any immune suppressive condition, like we have a lot of malignancy patients on chemotherapy, immunotherapy, and we have a huge organ transplant team and kidney and liver transplant. So patients of kidney transplant, liver transplant are also in this category. With a BMI more than 25, it is little too strict, but that's been found in the second wave that people who are slightly overweight also were sometimes having very, very severe disease. Patient above the age of 55 years with a history of cardiovascular hypertension, COPD, or chronic lung disease. So this is from the demographic profile and patient history. And otherwise, in the lab parameters, if the CRP is more than 70, our normal CRP value is 5, D-dimers 2 times, troponins high, LDH high, very high ferritin, then also they would be considered at a high risk patients. Now, once you have seen that the patient, you have categorized the patients into mild, moderate, and severe, you have decided whether you will treat this patient into a home care or in a ward setting or an ICU setting. Then we come to the treatment part. So in the hospital, just to have an overview, so we have a team of 10 consultants which do only home care consults. Then some of these consultants would take a round, but majority, there are 4 separate consultants who are taking the ward rounds. And these numbers are, mobilized according to the patient load in the hospital. Currently, we have about 50 patients admitted with us in the ward and ICU together. So we have 2 ICU consultants and 4 ward consultants who are looking after these patients, and obviously a team of residents and senior residents and nurses to look after them. So in the treatment part, if the patient is of mild case or mild or asymptomatic, we do not do anything. As per ICMR guidelines, we tell them to do an honest 1-week home isolation. Patient with mild disease, we give only symptomatic treatment with antipyretics and antihistaminic. At this stage, it is pretty clear that antibiotics like azithromycin, doxycycline, or antihelmintic like ivermectin, or antiviral medication like Fabiflu and all that is not doing any good. So we are not using it. But in milder cases, we do give budesonide inhaler or nebulization as per patient convenience. We consider monoclonal antibodies with the available in India is casirivimab and amdevivimab only. And this is basically for non-Omicron patients. But if the sequencing is not known, then we give early on to all the patients. Molnupiravir or a short course of remdesivir for 3 days can be added additionally to patients who have high risk factors, more than 2 high risk factors. Now, to the moderate group who are admitted in the ward, patients are given remdesivir 5 days, monoclonal antibodies if they are within the first 1 week of illness, and if they're proven to be Omicron, then it is avoided. If they are Omicron, non-Omicron, then we give monoclonal antibodies. And this we decide by doing a mutation test, which is currently being done as a research project. These patients are given dexamethasone only after completing 1 week of illness. Dexamethasone and methylprednisolone or hydrocortisone can be used interchangeably. The most important steroid is dexamethasone, but we do use methylprednisolone also. Hydrocortisone is used very sparingly. Anticoagulation is indicated in therapeutic dose to these patients, and we are giving low molecular weight heparin twice a day. The patients who are going into the ICU, we admit them into the ICU, start on methylprednisolone or dexamethasone, and after 24 hours, we see whether the oxygen requirement is increasing in spite of using steroids, whether the CRP is increasing in spite using steroids, then we use tocilizumab or baricitinib. Anticoagulation in prophylactic dose, if these patients are on HFNC, non-invasive, or on ventilator, they are given prophylactic doses of anticoagulation. If they go on ECMO, then according to the ECMO protocols, the anticoagulation is given. Mostly none of our patients in the ward or in the home care settings require antibiotic. Patients who are started on steroids are also not given as a dose of antibiotic. We do not start with the steroids. Even patients who are given tocilizumab, sometimes we give antibiotics, sometimes we do a blood culture after 3 days. And if we find the patient is going into any infective syndrome, then we start with antibiotic and antifungal, awaiting the blood culture reports. So usually, just giving a little brief on the monoclonal antibodies, so should be given as early as possible. If we are giving for non-Omicron, then tocilizumab and amdevimab. If we are
Please
giving for
mute
Omicron,
your
then it is
microphone.
sotrovimab, which is currently not available in India. The dose is 600 milligram. We have given to about 200 patients, and half of these patients have been given injectable IV as a infusion over 1 hour. Half of the patients have received a subcutaneous dose, and there is no change in the outcome. It can be considered in moderate cases also. We have given to 5 moderate cases where we are using double dose. It has a poor activity against Omicron in the lab, so it should be avoided in confirmed Omicron variants. Remdesivir is given 3 days to milder cases with high risk and 5 days to moderate cases. Usually by the time patient come into severe illness, the viremic phase is over, so we're not giving in those patients. We monitor liver function test. Usually we avoid in extreme end stage renal disease, and if the SGOT-PT is 5 times the upper limit. And usually benefit beyond 10 days is not justified. Maximum benefit is only when the patient is on low flow oxygen, less than 6 liters. And no benefit has been found in patients on HFNC, mechanical ventilation, and ECMO. Steroids, as I said, should be avoided at all costs in the first 1 week. It has caused more harm than any good. Give for the minimum possible duration and only when their patient is hypoxic. Higher doses of 1 milligram per kg body weight of prednisolone equivalent can be given. Bacterial and fungal infections, including invasive mucormycosis and aspergillosis, have been associated with prolonged use. And one has to be very vigilant in these patients where we are giving steroids, because of steroids, the patient will not mount any fever, and the clinical signs and symptoms of sepsis may be very, very subtle. So one should, at the suspicion, start antibiotics and do send blood cultures before that, both for fungus as well as for the normal aerobic bacteria. Anticoagulants have no role in OPD and home care patients. Like me, you will also come across patients who have been started on novel anticoagulants, Apixaban, Rivaroxaban, and all those things. So we do not give anticoagulation to home care patients. We do not titrate our anticoagulation as per the dimer values. All moderate and severe cases are to receive anticoagulation. In hospitalized patients, we do this. There is no correlation of D-dimer, PT, APTT platelet, or fibrinogen parameters to correlate with the risk of thrombosis. So it is not guided per these values. Patients who are receiving antiplatelets or anticoagulants because of any other condition which is continued until contraindicated. All hospitalized patients at discharge do not need no long-term anticoagulation. And when we discharge patients, select patients as per their IMPROVE score, we give them on anticoagulation for 1 month and sometimes 3 months, but not to everyone. We see their risk of thrombosis in them. Sudden deterioration in any neurological status, worsening of unexplained hypoxemia, or any new onset symptoms should prompt you to evaluate for any systemic thrombosis. During second wave, all of you must have come across thrombotic events. We had 2-3 patients who developed stroke even on when they were on therapeutic doses of low molecular weight heparin, and one patient had an peripheral arterial thrombus, and many had pulmonary embolism during the second wave. In this short experience of 2 weeks of third wave, we haven't seen much thrombotic events. Tocilizumab is another important drug. If we know when to use it and how much to use it, it is actually life-saving in many patients and lung-saving in many patients. So our simple rule is that acute deterioration between 7 days to 14 days, increasing oxygen requirement in spite of optimal steroid therapy, and rising inflammatory markers in spite of optimal steroid therapy. So we do a CRP on a daily basis, and if we see the patient is on steroids, still the CRP is spiking, and still the oxygen requirement is going up, we give tocilizumab. Usually 2 doses are recommended, but we give only 1 dose, and we give only 400 milligrams. So that has, initially we used higher doses, but we found that lower doses were equally effective, and actually repeating the dose of tocilizumab caused more infections. So we are using 1 dose, but some people do use 2 doses in 24 hours interval if there is no improvement or clinical deterioration. It is associated, sometimes associated with bacterial and fungal infection, and CRP may be normal after, blood culture may be drawn before starting the anti-infective measures. Common organisms which we came across after tocilizumab injection in COVID patients were candidemias, Klebsiella, enterococcus, because of the internalization of GI organisms. These are all gastrointestinal. So some patients can have intestine perforations, and there is increased permeability across the intestine, which can cause these infections. Contraindications to tocilizumab is high risk of GI perforation, prior biologic use, uncontrolled bacterial or fungal infection, active hepatitis B infection, or somebody HIV but not started on ART with a very high viral load, or if the absolute neutrophil count is less than 500, platelet count less than 50,000. Baricitinib is also we are using in moderate to severe cases, 4 milligrams. This is started with remdesivir once a day for 14 days. And it is should also, whenever if the patient is on baricitinib and is not doing well, and we feel that patient should go on tocilizumab, then we discontinue baricitinib and continue with tocilizumab. In our experience of patients, we did not find any additional risk of bacterial or fungal infection in these patients, but do not continue both these things together. That was it. These are basically the same contraindications which we use for tocilizumab. These are for baricitinib as well. Antibiotics routine use is not recommended, especially in those patients who do not have a healthcare contact in last 3 months. Hemodynamically stable patients do not warrant prophylactic IV antibiotic use even in the presence of steroids. Always send an appropriate blood culture and infection workup before starting or escalating antibiotic. Leukocytosis may be secondary to steroids or thrombosis, and it cannot represent completely as a mark of infection. C-reactive protein and procalcitonin may also not be very helpful marker of infection, so your clinical suspicion has to be very strong. Look for non-infectious causes like deep vein thrombosis, pulmonary embolism, thrombophlebitis, infusion reactions, etc. as an alternate etiology for fever. Tocilizumab have been associated with increased risk of infection, probably secondary to bowel translocation. So one has to be vigilant about febrile episodes or warm shock in patients after using tocilizumab. The common secondary infections which we came across after prolonged use of steroids is mucormycosis. Everybody knows the black fungus story in India after second wave. Aspergillosis is another fungus which we found common after prolonged steroid use, because some patients during the second wave, because of their bad lungs, were actually requiring it for 3 months, 4 months. Tocilizumab, after tocilizumab, especially after 2 doses, we found candidemia and enterococcus and Klebsiella bloodstream infections. In patients who were difficult to wean off from ventilator and prolonged ventilation, pulmonary aspergillosis was common. And in mechanically ventilated patients, VAP due to carbapenem-resistant Acinetobacter or Klebsiella was the notorious infection. So the changes which have happened recently is the addition of molnupiravir and remdesivir for 3 days in mild cases with high risk. Monoclonal antibody update against Omicron until unless you have this sotrovimab. Monoclonal antibodies in seronegative hospitalized patients can be used in moderate cases, except in Omicron. Anticoagulation is in therapeutic doses in moderate and prophylactic doses in the severe cases, which seems more like a paradox, but this is how it has been the international experience. Removal of remdesivir from severe cases, and baricitinib which was earlier in moderate cases, have been also added to the severe cases. So internationally, people are using Paxlovid and sotrovimab. We do not have access to these, so we have access to either remdesivir or molnupiravir or casirivimab and amdevimab. This is from NHS, where they can do the Omicron testing. So we are also, if there is a person with RT-PCR positive within 5 days, yes, and not requiring oxygen, then you do a genotype. If genotype available and it is Omicron, then you give sotrovimab. Non-Omicron, you give casirivimab and amdevimab. And if genome is not available, genomic sequencing is not available, and then start with remdesivir. So this is how they are doing, and that was my experience. I'm open to question. Thank you very much.
Thank you, Dr. Kataria, for your elusive and extensive.
So you muted.
No, can you hear me?
We can't hear you. I think you muted.
No, I have unmuted.
I can hear you.
Okay.
We can hear you, friend.
Thank you, Dr. Kataria. Can you hear everybody?
Yes.
Yes, sir, you are audible.
Yes, you are audible, sir.
Thank you. And really, it was a very elusive and very extensive discussion on adult management of COVID in the recent protocols and changes. We'll take question and answers later on. And I will request Dr. Abid to introduce and welcome Dr. Dhiren Gupta for pediatric management of COVID-19.
Thank you, Dr. Bhasin, sir. I would now like to invite Dr. Dhiren Gupta, Senior Consultant, Department of Pediatrics at Sir Gangaram Hospital, Delhi, who will be talking about the COVID-19 treatment in pediatric age groups. Dr. Dhiren Gupta, sir, please take over.
Thank you. And previous speaker has made my job very easy. And you know, there's a lot of questions, especially with the availability of these oral antiviral drugs. So that is really confusing the people. And sorry, yeah. So I'll be touching on that part also because I manage pediatric and adult. So my presentation, I thought that most of the things we know about. Just a minute.
Panelists, you please be ready with your questions so that we can take later on from both our speakers.
Yeah. So what I thought presently, what we are lacking, we don't know how Omicron is behaving in the society. Past 3 waves, enough people know. Even the common man knows that when to start steroids, what are the drugs available, how to use and misuse them. And even the latest of the kid in the MBBS first year, we call them, they know how to treat the patients and in most of the time. And we have misused steroid, we have misused remdesivir, and at least presently, we know that what we misused in past 2 endemic, but we don't know what the Omicron needs and how to treat. You will find many of the hospitals are giving monoclonal antibodies blindly just because they have purchased it. So probably we'll try to justify the management, right? So my aim is I'm going to talk about pediatric COVID management. Is hardly anything in pediatric COVID management. We know that except remdesivir in few circumstances. We'll go through what we already know and what is my experience with the Omicron, right? We know that Omicron is more infectious. It evades immunity and it's less severe. It looks like it has directly emerged from the alpha strain, that is the original Wuhan strain, rather than alpha, beta, gamma, delta. Means this sequence it hasn't followed. We all know that vaccination and monoclonal antibodies, which are available to India, is not applicable to the Omicron, which is amount to tune to the 95%. We have no way to diagnose the Omicron in our clinical setting, because even if we have got genes mapping, just like in our hospital, it takes around 5 days till that most of the disease process has either emerged as a severe disease or usually goes away, right? So now we have got kits where we can use an S-gene dropout, and very soon it will be available in each and every corner. Now, what we don't know, as I told you, when to start antiviral in an adult. As a doctor, I get a fever and I check it on second day, it's a COVID. Now we have got RT-PCR available, simple kits are available. Now by the next 6 hours, I know that it's just COVID. A drug is available. Should I start taking it? if I don't take antiviral within 3 days, especially oral one, molnupiravir, am I missing that window period? If I take after
Dr. Dhiren, 1
6
second.
days,
Please mute your microphones, Dr. Rumil and others.
Yeah, I'll stop there.
Thank you, Dr. Dhiren.
Okay,
Please continue.
okay.
Sorry to interrupt you.
So when I should take this molnupiravir or very soon we'll have Paxlovid, what are the indications? What are the warning signs? Like last time, we know that if fever is persisting over 7th, 9th day, it indicates probably you're developing pneumonia. So people used to get CT scan. We all know that saturation drops. Everybody knows that. It's a time to start steroids. Probably pneumonia is spreading in the lungs. So we know that when to give steroids, what's the duration of steroid, and how to do tocilizumab and how to manage in the inpatient. But what we know, what we want to know as a doctor, as an OPD patients in a low risk cases, when to start preventive therapy in form of monoclonal antibodies, in form of Paxlovid, in form of molnupiravir. Yeah, it's very difficult to pronounce and I'm learning. Second, what is the clinical course in Indian population? Means I put up one note in one of the international forum. Please convey me the course of the South African people, of American people, and how fast they recovered, and when they found that they are having pneumonia, what are the clinical signs and symptoms. So I did not get even one answer from them. When I should get an investigations, we all know that oxygen saturation dipping down, it's too late. So are there some red hearing sign everybody wants to hear? We all know that these are the SARS-CoV-2 mutants, and we started with alpha, then beta, then gamma, then delta, then epsilon, then zeta in Brazil, then comes eta, theta, lota, kappa, and lambda, mu, and now we are at Omicron. So these are so many mutations. And probably everybody knows that there are some mutations which leads to how to evade the immunity. There are some mutation which probably means is required to spread the infection. And one thing is that this virus wants to live long. That's why it's not killing us, right? So it's trying to develop a mutual understanding with the humans, so that I'm not going to kill you, so don't try to kill me, right? If you try to kill me, I'll have more mutations. We all know that how this Omicron is different from Delta. That Delta strains require TMPRSS. We all know that ACE2 is in receptor, but it also requires TMPRSS, and it attaches with the cell, and this way it produces large cells. You can say a large cells fusion of the cells. This fusion is required to produce pathogenicity, type 2, type 1 pneumocyte. And what is Omicron is doing, it is not leading to, dissolution of the cell membrane, but it gets engulfed inside like a pinocytosis. So that's why what is happening, it is mainly spreading very fast, but is limited to the upper respiratory tract infection. Upper respiratory tract like bronchus. So you must have heard this 70 times more in the bronchus as compared to Delta. But when the hamster lungs was infected, it was found to be more than means it is less on the lungs, and Delta was 10 times inside the lungs. So that's why it was producing more over pneumonia. What are the treatment options and spectrum when we talk about Omicron? 99% is acute COVID asymptomatic or just upper respiratory tract infection. In an adult high-risk condition, more than 60, poorly controlled diabetes, poorly controlled obesity, without hypoxemia, treatment available is antibodies, remdesivir, oral antivirals. Omicron COVID pneumonia, as previous speaker has rightly said, we need to suspect it early, right? Before patient actually desaturates, and we need to treat with them the steroids and those steroids for lower duration, just 5 to 7, 10 days at the most, and no need to get to give anticoagulant to most of the patients unless there are very severe cases. And post Omicron, that is long Omicron syndromes or MISC in pediatric, we don't know. None of the country has faced MISC till now. Let me share few cases which I am viewing, and around I've got 175 adult and 25 pediatric patients who admitted in various hospitals. This is a 13-year-old who is still with us, and she presented to us around 4 days back with high-grade fever. In the evening, she fell, means the day she developed fever, after 24 hours, she fell on the floor because it looks like a vasovagal. She was feeling very weak. And she was found to be in shock when she was brought to our emergency. Her pulse rate was 120, despite of giving 2 boluses. After giving 2 boluses, her BP was 80/30. So it was pretty low. There was no response to fluid bolus. IV norepinephrine was started with in the peripheral line and recovered within 24 hours. When I saw this child around 16 hours, her norepinephrine was stopped. And that time we didn't knew that she was RT-PCR positive because she had antigen negative. That's why she was admitted in ICU. So within next 4 hours, we got an RT-PCR positive. Surprisingly, CRP, blood culture, procalcitonin, everything was negative, and she was in shock because of your Omicron. Why I'm saying Omicron? Because past 4 days, we know that in Delhi, it's almost a 94-95%. Because it's a gene mapping takes time, around there's a gap of 7 days. This patient was given IV remdesivir. When we came to know that patient was in shock, and so we are planning to discharge tomorrow. Now, again, when we talk about any disease, especially if RT-PCR is positive, patient is very critical, we give a remdesivir in any critical patient, and especially we can give remdesivir in any age group, especially more than 3.5 kg is the weight if it is there. Like this is another child, a baby of a doctor, who came to me today morning that they want to shift the baby to the Gangaram hospital. This is a family positive COVID, all the cases, and he presented around 6 days back with a fever for 3 days. Then he became afebrile. Yesterday night, suddenly fever reappeared. It was almost 103, 104. Patient respiration became jerky. They rushed to the hospital. And once patient became afebrile, when I saw on the video, the patient looked pretty stable. He was taking orally, no jerky respiration, normal chest X-ray, blood reports were absolutely fine. So we need to know, we need to differentiate, is it a COVID a bystander or COVID-related just febrile illness rather than COVID-induced lung infection. So that is very important and for the clinical judgment. And especially when kids are afebrile, you'll find that they have started playing. So for pediatric patient, in an afebrile intercurrent state is very important. This is another, he's a nephew of mine who presented, who came to, who went to some centers. He got Covaxin vaccine 4 days back. Within 6 hours, he developed severe pain in the whole body. Paracetamol was given. Then following that, within 12 to 24 hours, there was high-grade fever with lot of perspiration and shivering. There was an intense chest pain with heaviness. Oxygen saturation dipped to 93. We repeatedly checked with different pulse oximeter. It was 92, 93. I was surprised, but I knew that during fever, there can be vasoconstriction. I've seen in the last 2 weeks, during height of the fever, even adult desaturate. Patient, he was investigated, CRP was found to be 10 because we were not sure that it is a COVID. Then COVID came positive, chest X-ray was normal. We stopped antibiotic. In fact, we just started 1 dose and we stopped. And the patient today, he was feeling much better except low-grade fever. So friends, during the height of fever, when especially it is more than 102, 103, there can be falsely low saturation. That is very important. And one more patient around 3 days back, His baseline saturation, he was around 34-year-old. His baseline saturation was 92. He's a Omicron, probably COVID positive, likely Omicron. And he used to smoke cigarettes more than 10. So I found that because we don't deal with adult, many of the pediatricians, that look at the smoking, if more than 5 cigarettes per day, very likely their baseline saturation may be low. This is another female, 45-year-old female. She presented with a fever for 8 days, afebrile for 24 hours, in between on 4th day. Now again started having fever. She's hypertensive, vaccinated. The vaccination is very important landmark. Feeling weak, she called me yesterday morning. No other foci. Her husband called me 4 days back. Now he's become asymptomatic. Her saturation is 98%. She's COVID positive, though because there was a gap of 24 hours. So I try to differentiate. Unlikely this is Omicron leading to pneumonia and progression of disease. There must be some intercurrent other ailment like UTI. So I was right. I started antibiotics and the cultures. So it was urinary tract infection and not the COVID and Omicron per se. This is another 58-year-old female. She's a case of uveitis and some autoimmune diseases on 20 milligram of prednisolone for 1 month. Past 1 month, she was getting steroid. She developed fever for 3 days. She became afebrile for 2 days. On around 6th day, she was COVID positive. On 6th day, she felt some tingling sensation on the foot. So saturation was checked. It was 85. Its saturation was rechecked by 2 or 3 different pulse oximeter. 87 saturation to 88 saturation was an average reading. This patient looks like a case of pneumonia, secondary to COVID. She was given, it happened in the just around 4 hours back, and she was given IV methylprednisolone, 80 milligram stat and 40 BD. CT scan showed, which was done around 2 hours back, severity score of 5/25, CRP was high, 36, and total count was 13,300. So this is an chest, this is a CT scan. So CT scan is not that severe. Means previously in the previous Delta wave, CT scan used to be showing worse picture than clinical. Here, clinical picture looks worse, and we don't know. It's just start of the wave. And what we could find that on the right side, small infiltrates, and even it doesn't looks like a 5/25. It looks like by 3/25. So, friends, a patient on immunosuppressant, which suppresses the fever, clinical features can dodge you. So always be careful. And in Omicron, 5th and 7th day are going to be important landmark. Look at the 70-year-old woman, and she's in hypertensive. She's not obese. Fever for 10 days, low-grade fever was persisting. On 8th day, HRCT was done. She is a relative of mine. I was not treating her. They called me around 3 days back for second opinion. So I took this case because it looks good case to present. And her CT score without, the patient didn't show desaturation, but score was 9/25. She was started on Dexona, so it was around 2 days back. Now she's afebrile. So at this moment, treatment is debatable. Are we treating the CT scan? Till when we can tolerate this fever in this patient? This was vaccinated patient and just one comorbidity, hypertension. She is not obese. Weight is just around 72 kg. So again, the debate continues as with the previous way. And now we come to my experience of the various patients. What I found that in 175 patients, very important is 60% had lot of shivering. Some of them didn't had fever, but had shivering. Cold is very important. That is the coryza, nasal discharge. Low-grade fever was more common, and high-grade fever that was more than 100, 200, 304 was just in 10 to 20% of the patient. Mild headache was almost in all, severe headache in almost 50%, and sore throat used to be major clinical sign and symptom. So as we know that Omicron mainly affect the upper respiratory tract. So it's a cough, especially wet cough, headache, sore throat is feature. And it's not like the loss of taste or loss of smell is not there. I've got two patients where loss of taste and loss of smell, and there was S gene drop, which was done in one of the lab, that is Mica lab. They did that S gene drop, and they found it S gene drop is there. Now, in pediatric age group, in 25 symptomatic, asymptomatic are numerous, especially between 10 to 17 years. Surprisingly, what I found that fever, especially high-grade fever with shivering, with perspiration, is a predominant sign as compared to young adult like 20 to 40 years. They are more symptomatic. But God, by the grace of God, all became afebrile within first 3 days, and nobody extended the duration of fever after 5 days. These are some admitted patients, not all with me, some of in the government hospital, and I collected the data from them. 14 symptomatic who got admitted, total were 12, 2 were newborns, and one presented with congestive cardiac failure with anemia at 2 months. He died, but I need to know the details, so I don't know the details. One patient presented with the congestive cardiac failure, 8 months with thalassemia. One is a preterm. It looks like a bystander. One presented with the septic shock, which I shared. 6 presented with the seizure. So febrile seizure is pretty common, or seizure with the COVID is not uncommon in the last wave also. And in 4 cases, it looks like bystanders. Now, I would like to answer few of the questions. Means the last speaker has spoken wonderfully. So I'm going to talk about what are the red flag signs. Is applicable to adults and adolescents, of course, and especially in poorly controlled comorbidities. We all know that drugs have been misused, especially monoclonal antibodies, by the name of non-delta patient. So presently, it's a 95% plus, it's all Omicron. And very soon the test will be available where you can detect S gene. No, we should know that Omicron has also 2 types of variety. 2A variety of Omicron can still have S gene, right? And it is a 30% out of all the Omicron. So nothing is 100%, but of course, we should know that in community, it is 90 plus or almost 100%. You may be dealing with just Omicron. So if fever is more than 100, 101 with medications and persisting beyond 5 days, of course, if patient is having breathlessness or drop in saturation, everybody knows that it's a patient is in a red flag sign. But the drop in oxygenation is happening around 5th to 7th day, a little bit early as compared to last time. We know that this time incubation period has shrunken from 5 to 3 days. Same way, everything has been shifted up. And low-grade fever, if persisting beyond 7 to 10 days. So these are the red flag signs that these are the patients we should investigate. And 6th day, in especially high-risk situations, we need to investigate. Probably we need not to over-investigate, just in CRP, or if 6 to 7 day symptoms are persisting in high-risk, poorly controlled comorbidity, if symptoms are persisting, you can get a CT scan. And again, as the previous speaker rightly mentioned, that D-dimer is not a very big game changer, because D-dimer doesn't give you an idea about the doses of anticoagulant or how to proceed further, but of course is an important marker. We know that in pediatric, what are the comorbidities? These are the long-term respiratory symptoms, conditions like chronic cystic fibrosis, interstitial lung disease, immunocompromised state, especially malignancy, cyanotic heart disease, chronic kidney disease, and in infancy and with poorly controlled obesity are going to be high-risk feature. This is the last 2 slides, very important and very difficult to answer. When we should give molnupiravir or monoclonal antibody in mild cases. This drug is of poor efficiency and it's just 20 to 30%. We don't know how much it is hyped up, the efficiency. The first 3 days, I'm in real dilemma. If I don't give this molnupiravir or other anti-oral, we know that we are losing the window, and most of the patient, 99% of the patient, even the high-risk patient, do get better by the 3rd day. So it's very difficult. It's a dilemma, like in influenza we always face. So in no even it's a poor efficiency, no role in even high risk patient. And my feeling is that it is subject for the discussion in a high risk patient like poorly controlled obesity, unvaccinated or vaccinated 6-7 months back, and poorly controlled diabetes. If symptoms are persisting after 4 to 5 days and not setting after 3 days, better to admit or better to give them remdesivir. We know that in Gwalior, we can give remdesivir at home very easily. It's pretty safe drug. So up to 7 days as a prophylactic, as a starting measure, early starting measure, we can give remdesivir. If this Plexovid or Sotamavibab comes, and of course, Plexovid has got better efficiency. Symptoms, again, Plexovid has been studied in unvaccinated patients, not in vaccinated with Delta infected patients. So probably these are not tested drugs in Indian circumstances. Even Sotavimab has been tested in a patient, without vaccination. And also the sera has been checked against, this drug, this new virus that is Omnicron. So if probably symptom persisting on 3rd day in high risk case, because the oral is available, so we can give it easily. And IV Sotamavimab in unvaccinated high risk maybe drug of choice. So in children, we know that there is no drug indicated other than remdesivir, especially if it is mild to moderate, shifting towards moderate and severe. MIAC is more problem than pneumonia. We don't know what is going to happen another 2 months. And less than 2 years, if you're dealing with critical disease, don't forget your HLH or severe combined immunodeficiency. They should be ruled out. Mefenamic acid and ibuprofen are good drugs which gives you better control. So I conclude my presentation in pediatric and adult. Moreover, presently is those who are getting admitted. COVID is usually a bystander. So don't go by the figure that, okay, so many numbers of patients has been admitted in this hospital and this hospital, because in any given disease process, if you get COVID positive, you are going to admit them in COVID wards. Severity is definitely less, and no use of drugs, especially oral antiviral, which is available. And remdesivir at some level, when you find that disease is not getting controlled even in the highest risk. Monoclonal antibodies is totally waste. In present scenario, it was justified 2 weeks back. RT-PCR sensitivity, now especially your rapid antigen kit, which is available in the chemist, is doing well. Means probably because of viral load, and it has been said that if you smear it with the saliva, though these kits have not been standardized, then you will get better sensitivity. But my experience is it's pretty good. And if your RT-PCR, the rapid antigen is negative, and your symptoms are persisting, then only go for RT-PCR. High risk cases, 4th day, 5th day symptom is persisting. In high risk, give remdesivir, and the less role of anticoagulant as compared to Delta or previous wave. No use of PPE, means unless you are going to ICU, you are just a good fitting N95 mask. Over the time, your PPE kit should be out, because we know that the spread by touch or by fomite, the risks are less. And we know that over the time of quarantine and isolation is reduced to 5 days to 7 days. And very soon you'll find that as soon as patient is asymptomatic, he should be out of quarantine. And of course, booster dose and pediatric vaccination. When you are going for booster dose or getting your kid for vaccination, be very cautious. Don't get infection there rather than just getting vaccination. Right. So thank you very much. And this is my number. Whosoever wants, means he can just WhatsApp me. Thank you very much.
Yeah. Thank you, Dr. Dhiren Gupta. That was very informative and elaborated in a very good way. I now request Dr. Bhasin sir to take over.
Thank you, Dr. Dhiren. And Dr. Alok Gupta, an eminent pediatrician from UK, is with us. I will request him. He is a senior consultant pediatrician, diabetologist, and clinical director, Department of Pediatrics, Dartford and Gravesham NHS Trust. Dr. Alok, are you there?
Yeah.
And he is my teacher, my senior, and he helps us a lot, in managing a lot of cases.
Very nice. So we would like to have your experience and your views, what you have seen in UK, and we know that Europe and UK have been seeing the cases much before, say 2 to 3 months earlier to what we see in India. So the wave comes later to our country, and your experiences. Can you please share your slides in short? Thank you. And
Can you see my slides now?
yes, we can see global
And,
COVID.
are they moving?
Yes.
All right. So before I really start, I wanted to say thanks to Gwalior IMA and Purendra and Premada actually, and who has given me chance to talk to you all. And it's always a pleasure to talk to my own friends and GRMC family members, colleagues, and associate. So it's a really big pleasure to me to come here. Despite short notice, Purendra contacted me a couple of days ago. So another really thing I want to say, I'm not the expert as compared to Dr. Kataria and Dhiren. Being in the right setting, being intensivist, it's always, they have a lot more experience dealing with severe disease, dealing with critically unwell patients and children. And my presentation is not my presentation, it's something we really presented to the trust recently, updating all the staff. But I thought it's quite a useful experience to share. Actually, it gives you context of what is global COVID and what we are facing in UK. So it's more about numbers, and numbers are more in millions and trillions, that kind of number we are going to talk about it. So we will struggle to even say those numbers in real language because they are significant numbers. But I thought it's a quite different kind of setup I'm going to set here compared to what Dhiren and Dr. Kataria said, which is mainly focused around the clinical treatment part, how to help clinicians. Can you hear me, or there's some noise in the background?
We can hear you. May I request all the others to please mute your microphones? My humble request.
Thanks.
Dr. Maheshwari, Sudha Maheshwari.
Yeah. So really, in terms of global COVID, and I think it's difficult to even comprehend those numbers, but they are in millions. We are talking about COVID positive across the world. And this data is valid up to 2 weeks ago. So it's quite recent data to share. And we know the mortality across the world is around 18% due to COVID. And we have given a massive vaccination program across the world again, but very variable and patchy across which part of the world you come from. And in UK, we are 4th in world ranking total cases. Not something to be proud of upon, but that's what we are really. 3rd in world ranking total tests. So we are doing a lot of tests now. So we are likely to pick up more number of cases being positive. So our number could be very high because we are testing a lot more compared to in some countries where the tests are not done that much. But the interesting news, and I think good news, is we are 30th in world ranking of deaths. I think that's something I think quite reassuring and consolation. And we'll come to know why we are 30th as opposed to the total number. We are hitting around 4th in the world. And that's really quite important point, and something that we can share with each other, as Dr. Kataria said, about mutual learning and experience to share. So this is a number again. We already talked about this, but this is more in graphical, and these are all WHO data. It's not like local UK data. And again, we can see there's different graphs highlighting America is highest in numbers, then Europe comes, that's where the England is, and United Kingdom. Southeast Asia comes as a number 3, Eastern Mediterranean, but somehow Africa remains quite low in number compared to the rest of the world. And that's something perhaps we need to learn about. When we even talk about Black population is at high risk, but what about in Africa then? that's really important point to firstly to learn about it. What exactly happening in Africa, where the number of children or number of people are less with COVID compared to the rest of the world. In UK, we already mentioned about it. There's almost like 130 million COVID positive cases, but that's really quite significantly less, around 18 to 20%. And a lot of vaccinations happening, and I'll come back to that vaccination part. This slide really is quite useful, and I can't see the full picture because the side panel is causing a little problem. But the London and east of England is really quite high, and that's quite London at least is quite understandable, because that's really hub for the country where a lot of people come and visit, and all the business goes in. So London is very high, but east of England is catching up as well, being quite high in number. This is an interesting slide, and I'm sure this will interest Dhiren and rest, thinking about age group of people affected by COVID and Omicron. And you can see that there's a shift now. 20 to 29 years of age is quite high number compared to elderly, high-risk population, or age group 0 to 4, I think is coming up as well, and 5 to 9. So younger age group is being affected a lot more compared to older age group, which was the case in COVID peak 1 and perhaps in peak 2. This is again, you can see, because we are doing a lot more testing. So that's why we are going to get a lot more COVID positive patients. Again, this is quite reassuring. The number of COVID positive people in the hospital are not as high as in the second peak or first peak. This is really, again, important message, and that could be the experience in India as well, where the population is much more compared to UK. Again, the ITU admissions remains low in number compared to peak 1 and peak 2. Very reassuring with Omicron. National COVID deaths again remains low in number in third peak compared to first 2 peaks. And these are really important information to share in order to get confidence and make plans around our COVID against COVID strategy. National ITU number remains low compared to first and second peak. And I think comparing even the different like period in the year, where we are claiming around half of the ITU cases compared to second and first peak. And again, there's a different comparison according to the time of the year. And I think really important is again, the orange graph really confirms that the number remains really still quite low compared to the rest. And this is really something perhaps India can catch up. So we got a 90% people in the country are vaccinated with first dose, and the second dose quite high, 82%, and the booster third dose, around 60% of the people are getting booster, and obviously country accelerating that program by even relaxing the age group where they can get either COVID vaccination or booster, either being family member being in younger age group, or if the other family member is in high risk group or frontline medical staff, they can be given, I think, vaccination. This is really quite important. And this is really interesting to see the people who are in ITU, they are really the younger age group population. Either they are not vaccinated, or they have a 1 dose or 2 doses, but not the booster. So the people who have a booster, so even in my own current ITU, the people 2 weeks ago, I had information about there were 4 patients, and 3 patients were unvaccinated or 1 dose. They were all Asians, and 4th one had a comorbidity like SLE, who had a full vaccination. So 3 were people who didn't get vaccinated. So vaccination remains, I think, key thing in order to at least prevent ITU admissions or mortality. ITU vaccinated versus population vaccinated relative risk. So you can see the people who have a full vaccination or booster, are they pretty protected and not reaching to ITU as much as the people who are unvaccinated or just had a 1 dose or 2 doses. So overall impression is that the people who are in ITU, they are younger, more female, more likely to be pregnant, and interestingly, more likely to be Black and minority ethnicity. But now we are beginning to see Caucasian population in ITU who are not vaccinated. We already said about this. So this is really because this was presented to our own hospital trust. So clearly we are a bit outlier because the Dartford is in the middle of Kent, but also is a part of London. So London, as we know, I think has got a quite high incidence of COVID. So we are influenced by London more than Kent. So our incidence of COVID is much higher compared to the rest of the Kent. And we got highest number of COVID in the Kent. And we can't really do prevalence data because this number is changing all the time. And we don't know exactly, we can't predict reliably how much we are going to get in a whole year. So I think this slide is more for local use, but we are expecting, I think we may get a peak of this third wave is around 1st of Feb. But my feeling, I think first we've already seen the peak. So because especially in children and even total number of hospital with COVID patient, we gone up to 140 patients in my hospital, and we got around bed capacity of around 550. And now we are started dropping to around 120 to 130. And number of children are low, which is a really good news for us. I think about between 5 to 10% inpatients are COVID positive, either because of COVID illness or they are presented with something else, but COVID was found to be there as a part of the screening, as for every patient who gets admitted on the ward, get COVID screening. But what we are anticipating, if this prediction goes right in terms of peak around 1st of Feb, then we will struggle because we will have another 100 patients in addition to another 130. So we'll be dealing with 230 patients in a 550 bedded hospital. And we have a ITU bed around 10, but then we'll go up to 15 ITU patients requiring with COVID, along with other patients requiring COVID. So we will really struggle. So the plans for the hospital is to create another 100 beds as a part of contingency plan, which could be quite challenging. So overall mortality is around 22%. The important message in this is a lot of there's like a hospital acquired COVID. So patient is coming with something else but getting COVID. That's important point. Number two, patient is presented with something else but also coincidentally have a COVID. So that is called imported COVID. So that's really quite important. I think how do we keep nosocomial rate low? First, strict mask use, I think, and hand washing. I think the two important things. I think Dhiren said, I think PPE may not be necessarily full PPE required, but I think mask use, good fitting mask use, and the hand washing are really important, and obviously the social distancing. And how do you screen these patients who are acutely unwell, who coincidentally have a COVID? So maybe COVID point of care testing at the front door. So when these patients come in the hospital, make sure we get point of care testing for COVID, which we do. So obviously our mortality compared to rest of the, I think is high, as we said, 22%, and that could be I think more reflection on London. And I think our risk is not necessarily high. So clinical picture, I think, is a different population the previous waves we are dealing with. As we said, I think is more young age group population is we are dealing with, I think, more affected. Omicron far more contagious. We know that. I think 3 weeks ago, I think it was more Delta. I think we're dealing with 4 weeks ago, but now majority of patients, I think Omicron, and it's very contagious and a lot more in community than in the hospital because they are not that unwell. And a lot of them, they are asymptomatic. So even we don't know whether they have a COVID. I think there's a lot said around the treatment of COVID, and we had, I think, experts, I think, though they didn't claim them expert, but they got a lot more experience than all of us. So I think it's worth listening to them. But one of the important thing in the UK setup is that the patients who are in high risk group, then they have access to neutralized monoclonal antibody. So we have made an arrangement from 16th of December. Those patients can be given monoclonal antibody by backdoor. They can still come to hospital, can be given, I think, as a ambulatory option, and then go out, I think, within 3-4 hours. So that's something started from the age of 12 onward, or which child is more than 40 kg, to all the high-risk patients who are not clinically unwell requiring hospital. So really we feel, I think, and that could be quite applicable to all the healthcare system, where we need to worry about the patient safety, because we have a limited amount of capacity in terms of escalation area and the diluted staff. There's a lot of sickness, up to 5 to 10% staff being affected. Either they contracted COVID, or they are in contact with COVID patients and vulnerable now. So I think that's really, so we are working at a very strained, I think, workforce and space environment, and that's something we need to keep in mind. Patient safety, I think that's really, again, gets affected when we are stressed as a system. Patient safety, again, interferes with normal activity, but staff safety is really quite important as well, especially if they are not vaccinated for one reason or other. From April, I think we are making it mandatory for frontline staff to have a vaccination. If they cannot have it for one reason or other, then we need to think about redeployment of that staff to the appropriate, safer places. And obviously, this is all causing tiredness, fatigue, emotional well-being is affected. So we need to think about how do we support each other in order to maintain that workforce who can really help to look after the needy people. Thank you. I think that's the end of my presentation. And
thank you, Dr. Alok. I really appreciate and thank you from the core of heart for giving us the insight of world COVID or global COVID. And a lot of things we have gathered. We will have questions from you also. And let us start question answers. Dr. Abid, do you have any question in your mind?
Yeah, thank you, Dr. Bhasin. Actually, there is this very common question that arises from a lot of clinicians, which was debatable in the second wave as well, on the choice of steroids. There is a wide belief that dexamethasone is superior considered to MPS methylprednisolone, and the dosage of each. So if our experts here can elaborate on this, I think it will clear a lot of confusion in our minds.
Okay, I'll take this one. Okay, right. Yeah. So you're right. There is a lot of confusion, and which still prevails whether dexamethasone, because the first study, the well-designed study which showed a mortality benefit came with dexamethasone. So if you're choosing dexamethasone, then you're politically very correct. Personally, I like methylprednisolone more than dexamethasone, but yes, so it's kind of that. But dexamethasone, usually we use 4 times the dose of dexamethasone. I mean, with methylprednisolone, that's how the conversion goes, and 7 times if you have to use the hydrocortisone. People have used really mega doses of methylprednisolone in the past. When in the second wave, people were using pulsing like 500 milligram once a day for 3 days. I have not used it, and I don't believe in that also. But maximum we go 2 milligram per kg body weight of that person in methylprednisolone. Up to this limit we have used, and then we de-escalate quickly in 5 days time. That's what we used in the second wave. Fortunately, things have not been this desperate right now.
Okay, so your choice is methylprednisolone, then
Yes.
rather than dexamethasone. And Dr. Dhiren, can you quickly comment on this? Your experience?
I totally agree with that. My choice is methylprednisolone, and that also depends on the severity of disease, the dose, and normally I don't go even the severest case which is admitted beyond 80 or at the most 125 one bolus. Otherwise, Maximum dose which I use in a day is 80.
And duration?
Duration again, So, suppose in a patient where CT score is around 12 to 14 and oxygenation still not 93, less than 93, but 95, and cytokine markers are high. So I start with something like 16 once a day for 5 days, then 5 days tapering. If patient is hypoxic, like saturation is like 92, 91, then I start with 32 one morning, evening for 3 days, then 32 once a day for 5 days, then tapering. I mean to say, not more than 10 days with tapering, or at the most 2 weeks with the tapering. So in first wave, of course, I used it for at times up to 3 weeks, but in the second wave, I started with high dose in hypoxic patient and then tapered it over 10 to 14 days. Means this is the usual protocol I followed. And as you know that in second wave, most of the patients who were admitted during first wave, we were bound to treat them in home.
One question is that can you briefly outline the management of COVID as per the severity? And because this is the question which is being asked from many participants who are, there are many doctors who have logged in and they are listening to our webinar. So this is from Dr. Vinod Kumar Jain, ideal line of management, and many have requested this. Then we'll come to the vaccination and other questions quickly.
Vinod sir is used to be our neighbor. He is my brother, means I used to
elder brother,
So,
he's and very, popular clinician in town, of the town.
In IMA NP, they just gave me 2 days or 3 days that you want, and I couldn't say no. I thought of that I would say, but Madhya Pradesh and Gwalior is so near to me, so I couldn't say no. And
thank you.
This is the reason that you come to know. I know you so well, and everybody I know. So it's so familiar than Delhi for me, though I'm in Delhi for 26 years. So having said that, again, as previous speaker has rightly said, that things unfortunately has not been protocolized in India. What happens in the from people from AIMS or very big government institution who are spokesperson, they've hardly seen any COVID patients, right? They are, or people from other branches who have never encountered a COVID patient, they are real spokesperson of the hospitals. And those who have seen the patients don't make the guidelines. That is the unfortunate part of India, right? So it's a clinician's duty that they have customized the management as per their experience, as per their needs. See, Omicron, we are in third week, means almost in second week of Omicron. There is no national guidelines for treatment available to us, right?
I agree.
When guideline will come, when this is going to wean, this epidemic is going to wean, and they will take some Western study, will compile in horseshoe, and they will present.
The same thing happened in second wave also.
Yeah. So something like, we always believe in post-mortem, then and prevention, something like that. Anyway, so I'll just share what most of the people agree. A patient, I try to categorize a patient is a high risk, low risk. There's a high risk situation, high risk predisposing factor, and high risk situation. High risk predisposing factor like 60-65-year-old, poorly controlled comorbidity. Especially 2 factors are there, like obesity with hypertension or diabetes. Diabetes, we know that is the worst of all. Diabetes and obesity is the worst combination at all. So you analyze that this condition is in high risk condition, high risk predisposing factor. Second is a high risk situation. High risk situation is like even a 26-year-old who is having persistent fever, high grade fever on day 6, day 7, day 8, right? So even without comorbidity. So these are the patients where my tentacle will stand. Okay, these are the patients who can land up in problem. So in the first situation, say, if there are no fever persisting, even in a diabetic, in a obese, 5th day onward, nothing. I won't do anything, no testing at all. Especially with Omicron, We know that even in the highest, say, I showed you 175 data, and around 30% were actually with comorbidity, with previous existing lung diseases, with hypertension, with diabetes, and everybody got settled within 5 days. So why to investigate? And some of these people got themselves investigated. They got CRP value of 12, 26, IL-6 value of 26, but no fever, no symptom. So it confuses you, right?
So, Dr. Dhiren, can you cut it short? In mild, moderate, severe, how you are going to address these patients in very short time?
Yeah. I'm not talking about those patients who are hypoxic, whose saturation is less than 94. Everybody knows that you have to start steroids.
So should we give an antibiotic to mild cases, and what treatment should be given in mild cases which are at home?
Sir, first of all, no ivermectin, no antibiotic, no azithromycin, no doxycycline. And I was surprised to see the prescription carrying these drugs this time also. I thought that probably past 2 seasons people didn't learn, and because we didn't have guideline, now we are very clear. Vitamin C, vitamin C, zinc, no, nothing has no role. So it is just a symptomatic management. Your paracetamol with some gastritis preventing medication, that is the only medication required in mild cases, and with continuation of antihypertensive and diabetic, right? So means it's very clear that there is no role of oral antimicrobial, so an oral antiviral drug in most of the patients. Like, so one is steroid. So I told you steroid, if you find CT scan score of like 16, 17, 50% of things are infiltrated, and patient is persistent to have low-grade fever or high-grade fever, then you start steroids in these patients other than hypoxemia. Now we come to the second part. That is nowadays major difficulty, major problem is when to give this molnupiravir. Which of the group patient we should start molnupiravir? Even in the patient with the highest risk, you will find in 99% of the patient, they do settle within 5 days. So on day 4 or day 5, that's why I brought that case. On day or day 5, if you find fever is persisting in a very high risk situation, then you should consider these drugs. If Paxlovid would have been available, I should have chosen. Otherwise, on 4th day and 5th day, if fever is persisting in high risk situation without hypoxemia, I would like to give them remdesivir. And regarding severe, previous speaker has clearly mentioned, in a severe case, you are going to give not only antiviral, but steroid as well as anticoagulant. But in moderate cases and in mild cases, unless severe hypoxemia patient is going towards, there is no role of anticoagulant also.
Thank you. Dr. Sunita, Dr. Kataria, one thing is there, any role of monoclonal antibodies, and how to differentiate early between cases of Omicron and Delta variant? Is there any method of differentiating other than the genome sequencing?
I'd like to add one point on this.
Besides genome sequencing, there is, sorry.
Yeah, ma'am, 1 second. We'll just elaborate that the monoclonal antibodies, it is said that for Omicron cases, we're not supposed to use the one that is available to us. So how do we know when to give, when not to give?
All right. So there are a few things, like if the RT-PCR is doing 3 genes in which one is S gene, then the drop of S gene will give you an idea. Secondly, Tata has made some RT-PCR, they call it Omnisure, so probably that would use something like this. What we are doing is that we have a technique of doing a gene mutation. So we pick up 6 mutations which can tell whether this is an Omicron, whether it is a Delta. And this gives results within 1.5 hours only. So this is being done recently. We have actually done mutation in about 50 patients. And out of these 50 patients, we found 40 had Omicron, so which is about 60%. 20 were not non-Omicron, Delta plus. or something. So I found this very, very clinically relevant. You do an RT-PCR, you don't have to do it in every patient, but where you have to make a decision, you can do this. And if you find it is non-Omicron, then you can use monoclonal antibodies. I would here differ a little bit from Dr. Dhiren Gupta, because, earlier the better. And monoclonal antibodies have shown to change the trajectory of disease. After 1 week, when patient has gone into an immune hypersensitivity or a cytokine syndrome, then there is no use. So I am a believer in using monoclonal antibodies, more so in Delta variant with any 2 high risk factors, which I enumerated. And in Omicron, we have recently procured sotrovimab for somebody, and we have given that.
Purendra, can I come in just to comment?
Yes, sir.
Purendra, you're muted, but I will start.
Yeah, please, sir.
Just really to say this, in terms of mild, moderate, severe disease, which you are trying to ask Dhiren actually. As I said, I think Omicron, I think it all depends upon whether the population is vaccinated or not. They are healthy population or not. Yeah, they are in high risk category or not in high risk. That is something I think as a doctor, I think as a clinician, you need to really make a judgment call as soon as the patient come in contact with you. Okay, they are high risk either because of clinical disease or high risk because of their bio profile. Okay, they are high risk because of diabetes, obesity. But majority of people, because we are not doing enough testing, for example, they are not coming to you anyway. And that will be fall in mild category. You know what I mean? So they won't come to you because they have a mild cold, not being tested. So majority are not coming in contact with healthcare professional to start with. But when they come in, you need to definitely make sure they are not in high risk categories, either because of diabetes, hypertension, obesity, immunosuppression, that kind of stuff. And then you will decide whether I think that the role of monoclonal antibodies in high risk category who are well enough to prevent them to become unwell, requiring ITU or ICU. It's really important to make sure we intervene, as Dr. Kataria is trying to say. We need to prevent that progression because they are already, and that's what NHS England has agreed from 16th of December to give, I think, monoclonal antibodies to those high-risk patients who just found to be positive on COVID but clinically well. They've not been to hospital as yet. So we populated the list now of those patients in a small country where we know who are exactly high-risk patients. And if they are found to be COVID positive, we bring them in, give this monoclonal antibodies, and with hope, they won't become worse. And that's so important, I think, in vulnerable population, elderly or associated medical condition. That's really important. When it comes to moderate to severe disease, you already been in contact with doctors. Yeah. So then I think they will decide what is the best course. So I wouldn't worry about the moderate to severe, to be honest. Obviously, this is August audience, we want to learn from each other. And that's not that difficult by talking to each other, these guidelines. I think the mild one, asymptomatic, are the crucial one to ensure, I think, we are vigilant around it.
So just one point I want to make. I need to say what everybody is saying is the same thing. 2 weeks back, if a patient comes to me, there are 60% chance that
please mute yourself, Dr. Ram Bhojwani. Please mute yourself.
So what I'm saying that situation is hyper dynamic. It's changing very quickly. So 2 weeks back, if you would have done genomic sampling, then 60% chance it was Omicron, 40% chance it was Delta. But now it's almost 95% is Omicron and 5% Delta. Now we have got two situations. One is we are not able to get a genomic sequence within hour or 2 hours where we have to make a clinical decision. And second is that where we know that it is Delta or it is Omicron. If it is Delta and patient is having all the features of high risk, then you are going to give this monoclonal antibodies. We have used in enough patient and it definitely helps in almost 70% to decrease the hospitalization. Now in present situation, if out of 100, 95 are Omicron, then monoclonal antibodies can be given, but not of that as a Roche or that which is available in India, but of course, sotrovimab. So I just want to inquire from Dr. Alok, which antibodies they are giving, and what is the profile of, what is the spectrum of virus at your area, and why you are
I think, Dr. Dhiren, we should limit this because let us leave this to the judicious judgment of the clinician at that time. I think we got it, what has to be passed to the audience. Yeah, thank you. And then another question is regarding the vaccination. This vaccination, whether we should give a mixing of the vaccination should be then those who have taken Covaxin before, now we should give them the Covishield, or Covishield they have taken before, or we should use the same. Any, Dr. Alok, can you give this, anything you can add to it? And Dr. Dhiren and Dr. Kataria also, I would like to ask, because this is
regarding
regarding
the booster doses.
Regarding the booster doses, which is now going to start in India also. So shall we mix it or shall we go for the same? Dr. Alok. Dr. Alok, please.
Yeah. So in UK, obviously, they were not very particular or strict around it. What you had as a COVID vaccination and what you're going to get as a booster. So they given everybody Pfizer vaccine as a booster, and regardless what you had as a primary vaccination. So they were not very strict or contraindicated against one over other. So it was something they used as a one vaccine, Pfizer one to everyone. Does that make sense? Is it clear enough? Thank you.
Yeah.
And Dr. Kataria?
I think the government says that you have to give the same, but my personal view is that mixing would give a more holistic immune protection. So I would vote for that, but we have to abide by what ICMR and DCGI says. Even the study on mix and match, which was done in Gwalior, was found to be more effective than the same vaccine. And even some accidental mix and match which happened, and ICR itself concluded that, that's better than single one. So I think there is a little dichotomy here, but we will not contradict the government and not confuse people furthermore. Let's give whatever was given.
Okay.
That's a small point, actually. One, America has gone in the same way as England. I think it doesn't matter which vaccine you got. That another thing, they have not used AstraZeneca vaccine as a booster. I think it's really worth mentioning. That's why I'm sorry I had to come back again. But they have not used AstraZeneca purposely because there's incidences of various other problems. So that's something to be careful about.
Yes.
I think, sir, even in Australia, there is the same thing they're following.
What the study has shown that if you were using Covishield and you use Covishield as a booster, it induces 3 times the antibody response, and that is not very high. And if you use an mRNA after getting 2 Covishield, then definitely it is going to boost us. And now, secondly, even people have tried Covaxin after getting 2 Covishield. The response is not very great. So in Indian context, things are very different because the vaccines which we are using are different as compared to UK, because UK, they have got people, when they started with Covishield, then they come to mRNA. The whole country thought that, okay, they were cheated because they were given less efficient vaccine than mRNA. So Dr. Alok will agree. So probably Indian circumstances are very different. Unfortunately, not very good studies are there. As per Dr. Kataria also, those studies are very, that doesn't have very good value. So probably whatever government is saying, and do that thing. And I've given myself Covishield. I've used 2 Covishield previously, and after 4 weeks, my antibody response just before getting booster, it was 8. And after 4 weeks, it is 145. So it's quite good response. So whatsoever government is saying, I think it makes sense.
Okay. Hello.
Yeah, we can hear.
Regarding this vaccination, one last question. Should a previously COVID infected patient, like in the 2nd wave or in the 3rd wave with Omicron, should they get vaccinated, and the booster dose should they take, or they should delay it?
Can I answer?
With this,
Yeah,
Sir,
ma'am, please.
Yeah, ma'am.
I just wanted to make this. There's people who have been infected earlier with 2 vaccines are also getting Omicron, and boosted or non-boosted people are getting it, but it is a milder infection in those patients. So currently, to say through this particular, I think it may not be very helpful, but yes, for future they can take.
Okay.
I am thinking that in near future they are going to club the influenza and COVID vaccine and will all be taking every year.
Dr. Dhiren,
Yeah, ma'am.
say.
I totally agree with that. And because presently is the peak of epidemic, right? I would not advise them to go to vaccine center, and because this booster is not going to how much this is going to act on Omicron, or whether actually we need to prevent Omicron. So it is such a milder infection. It is for the other, new variants which are going to come over say next 2-3 months, and for that we are going to boost us. So presently, one should refrain from getting booster unless they can get it very safely without overcrowding.
Can I come in? Just a quick comment, actually, as India has got very different setup, actually, with a lot of diversity and crowding and all this. So I think I'll take Dhiren's point, I think. But in terms of UK advice, and I think which is again, I've shown a number of slides, actually. Where the numbers of ITU admissions, number of hospital admissions, and now UK is thinking about another dose of either the vaccine or booster. So you all are really had 2 vaccine doses, 1 booster. Now they already started the 4th dose. Either you call part of the vaccine or booster, another booster. And I think the important thing, the message is still clear. I think they will persist on that. Even we don't know enough data around the Omnicron, whether it's really protecting Omnicron or not. But the government here already started on 4th dose, and they already started with the high-risk population and frontline workers. So I think it's a time to watch out and see what happens in the UK and in America, because those countries perhaps they are a few weeks in advance in terms of Omicron and rest, really, and that will really help us for India to decide whether we need to get, but we need to take in the light of this safety, the benefit and risk, because there are hundreds and thousands of people outside vaccination center. That creates more risk, I think, to get a COVID compared to getting a protection from booster. But here we already started 4th one.
I think what everybody wants to say is that with the booster on, they can get COVID. With the vaccination, person can get COVID, but the severity of disease will be less.
Correct.
I think that is the message which we should give, and everybody should give. And as you have rightly said, that they are UK, they are planning. They have already started. They planned for the 4th wave. And this is the question. I think Dr. Makija's question is being answered in this direction by this reply from all 3 panelists. Dr. Abid, you can take another.
Yes, Dr. Raju.
Yeah. Hello, ma'am. I wanted to ask a question with ma'am. Ma'am, there is a controversy regarding this drug, oral molnupiravir, because recently the ICMR head has given some controversy because it has not included in the national protocol, and some adverse reaction is also related with like genotoxicity and the mutagenicity. So what is your take on when should we start, because it is recommended for mild to moderate cases? So what is your take on?
Dr. Kataria, are you? Dr. Kataria,
Dhiren, would you like to?
I think I'll try this.
Yeah, please, Dr. Dhiren.
Just go to the previous one, that high risk situation should get booster safely, because it is going to take another 2 weeks to have peak best effect of the booster. So we all high risk, especially the last vaccine gap is more than 6 months. We should take booster and try to take it safely. That I want to convey. Definitely it helps, and I've taken booster a month back. Now we come to the second question, that is molnupiravir. Molnupiravir, out of all, I prescribed to only one patient. 10 of those patients were already taking molnupiravir when they consulted. And believe me, there was no effect on the symptomatology. All of them were getting towards asymptomatic period on third, fourth day. This drug is again, its efficiency was considered to be as a 50%, then reanalyzed to we have 30% efficacy. It is like an influenza situation. In an influenza situation, you choose, okay, on third day, very high grade fever, very severe headache, and patient is probably going to worse and is going to high risk situation, better to give molnupiravir. But in a low risk situation, when the efficiency of virus to cause virulence is so less, in 10,000, only one chance that it is going to precipitate pneumonia, what's the use of it? So in nutshell, a very high risk situation where monitoring is not possible, and you find that third, fourth day disease looks like a worsening, then this is a situation where you have got two choices. One is available remdesivir injectable, and second oral molnupiravir, that the effect is very less. So choice is yours, but this is not a wonder drug. This should not be misused. There are many prescriptions on day one, things have been prescribed. Probably this is overused, misused, and exploited drug.
So my question is, as Dr. Ujjwal wanted, I think, whether to start remdesivir in such cases where in spite of third or fourth day or fifth day, patient the symptoms are worsening.
They are better. It's a better drug than molnupiravir, and efficiency-wise also. And because otherwise you are losing every day is important. So it's a very high risk situation worsening on day 4. Day 4 is probably the day 4 and day 5 is an important time for any patient where clinician has to take the decision. So in my almost 30 patients, I thought of day 3rd. I waited for 24 hours and everything got okay on day 5th. So probably day 4 and day 5 is very important. And to decide drug of choice, if possible, is remdesivir, and what we are left is molnupiravir. But it is not a wonder drug to be started on day 1 in any case.
Correct. I think the message is very clear. Dr. Kataria, are you there? Would like to add to it? Okay.
Another thing is, sir, I'd like to ask is anticoagulants in post-COVID patients. I mean, extended use of anticoagulants. What is your take on that?
Studies in the as per the Delta wave, they have found that those patients where this anticoagulants were used during hypoxemic period, extended use was beneficial. But again, Omicron is very different virus, and till date, I have only seen 1 or 2 patients with actual pneumonia due to Omicron. So I don't know how much it is going to benefit and how much thrombosis this causes.
So post-discharge anticoagulant should be continued?
Around 2 to 4 weeks.
2 to 4
Dr.
weeks.
Dalmia, are you there? Do you want to ask any question relevant to cardiac?
Yes, sir. Just I would like to make a point. Dr. Abed was talking about the role of anticoagulants post-discharge in the patients. So there are guidelines from the American Society which says that all those patients who are aged more than 75 years, patient who has got comorbidities in the form of malignancy and presence of a documented episode of a pulmonary embolism. All these are the candidates which should be given oral anticoagulants for a period of say next 30 to 40 days. You can give rivaroxaban 10 milligram or apixaban 2.5 milligram twice a day. So these are the recommendations only for those patients which have got a high risk or a high score post-discharge.
Okay. Dr. Anupam, any question from your side? Dr. Anupam Thakur is pulmonologist here.
Yeah. I want to ask, is there any difference you find between last epidemic and this epidemic? Because this time we found a lot of vaccinated patients coming to our for admission or with the disease. Is there any difference you find?
Yeah. Today it was 25,000, and last year in Delta when we had 35,000, Dr. Anupam, means almost 70% of our hospital was full. And till date, as per COVID pneumonia, means I'm not talking about because of comorbidity or because of any disease. As per for the COVID pneumonia, there are not more than 4 to 5 patients.
Okay. So there is a effect of vaccination after, so you don't find so critical patients on that.
I think Omicron itself is a milder variety, doesn't penetrate the lung, and more so over with the vaccination. And we know that it evades the immunity of the vaccination. And despite that, we were vaccinated few months back, before 6 months, but still it doesn't affect lungs that much.
Yeah, sure.
And that's the same experience I shared now with UK. They are more contagious, less virulent. So there's so many patients in community, but they're not accessing healthcare services, at least to secondary care level, like what we call hospital. So hopefully that's a really sort of hope, I think, and assurance we have with this new variant. Hopefully we'll manage,
that's why, So that's why I insist that monoclonal antibodies, looking at the severity of the disease, is more often misused.
Nephrologist, Dr. Dr. Manish,
high risk cases, I think.
We see Dr. Manish Gupta, senior nephrologist of Gwalior town. Dr. Manish, please, if you have any questions.
My question is, Dr. Dhiren sir, just want to know that being a nephrologist, a lot of our patients are on basically AC inhibitor and A2 receptor blocker, which is considered to be slow the progression of the renal disease. So what do you take on this patient who was already on AC and A2 RB? Should we continue?
I think what is recommendation is that you continue with everything. Means when the first wave came, there used to be daily we used to get some new article that those patients on ACE receptor inhibitors will have more severe disease. Then they found that ACE receptor inhibitor used to be preventive, something like. I think now we are very clear. No drug is preventive, no drug can save, and because it is the vaccination and the Omnicron virulence that is benefiting the population. So you need to continue whatsoever you are giving for that patient. So there is no protective role or no harmful role of any hypertensive or any renal protective medication what you're using.
Thank you. So one more question. We'll just so early intubation versus NIV. This is something that needs more elaboration, because there's a lot of confusion.
Nobody wants to intubate these patients unless you are pushed towards the wall, and that is applicable to pediatric COVID with severe pneumonia, adult COVID. I worked in adult COVID. I didn't work in adult intensive care, but adult COVID, and I myself have intubated around 3 patients, and I know that what the outcome of these patients. So it's very bad. So, but anyway, early intervention before the patient actually become gasping is definitely recommended, and you have got a lot of options if you save their brain, and if you do any intervention very late, you just neglect it, and when patient started gasping, that is pretty late. So you have to choose, but not too early, because in pediatrics especially, NIV works wonderfully. Even in the severest of lung disease, it works wonderfully. And in adult, to some extent, if too many comorbidities and very high age group like 80-85, we know that most of the things are futile, unnecessary. We try to prolong the things.
Yeah, so I completely endorse Dhiren's point. With our experience here as well, I think if it's going to be intubated ventilated, it's a bad news. And we are talking about 80% mortality. And NIV, BiPAP, OptiFlow, they are very effective method. But again, I think going back to the basic is really seeking early medical help in certain cases. And one thing really what works, at least in UK, but I think we got a system in India as well, integrated care model, where I think primary care physician have access to secondary care and then access to people like Dhiren. sitting in
15 मिनट में हो जाएगा.
so important and powerful. If you got a patient, whether we got a mechanism of WhatsApp where you message each other and then really pick up those cases who are likely to become unwell or rapidly unwell. And those are the patients really need to be helped, I think, you know. So that system, I think, exists in India, may not be very structured way, but because of professional goodwill, I think we all connected with each other. So that's the important point, I think, in order to prevent that population getting very unwell and presenting too late to the system.
Thank you, Dr.
Thank
Alu,
you,
for your valuable comments. Any question? Our HOD pediatrics, Dr. Ajay God, is with us. Dr. Ajay would like to ask any question, sir.
No, thank you, Purendra, and I'm really enjoying the listing of Dhiren and Dr. Kataria. And
I can ask a question to Ajay. Ajay, what's your experience in children in hospital? You can share your experience in children.
Please mute others. Please mute.
No, right now in the
Dr. Ravi, please mute yourself. Dr. Dalmia. Dr. God, sir, please.
Yeah. In fact, in the present scenario, we don't have any kid admitted. It's very fortunate situation in Gwalior that though some cases are positive, they are more adolescent, and we don't admit. There is no need for admission. They are all having the very milder symptom. It's very fortunate condition, and we have prepared ourselves with all the old experience of the first and the second wave, and you know, there are, as Dhiren said, there are very few drugs which are really indicated in pediatric population, and we have all the drugs with us, and we don't want that this time should come, and so that we should use these drugs, and it's a very still very fortunate situation, though 200-300 cases are positive, but they are the kids are not having a very severe disease, and I'm really enjoying the presentation of Dhiren. Dhiren is a gem. He knows each and everything. He is very inside of the COVID. Even we are many of the time we are also taking personal advices to Dhiren, as he is having the experience of treating adults also in the Gangaram Hospital. Thank you, Dhiren, and thank you, Purendra, for aiding me in this conversation.
Please be with us. Thank you. Dr. Nilima, are you there? Do you have any question? And your experience was tremendous as in super specialty hospital, and you have managed very well the last 2 waves.
Sir, I like to ask, can you listen me?
Yeah, we are listening. We are able to hear you. Yeah, please go ahead, Dr. Nilima. Dr. Nilima Tandon, are you there? Okay. Dr. Manish Sharma, do you hear us? Dr. Manish? Yeah, please, if you have any question or your experience in the last 2 waves.
Yeah, obviously in first wave, we have not having the option like remdesivir, but of course, patients are living very well, as we all of us very well aware that remdesivir having no any role in mortality prevention, but it's having its role in recovery. So obviously in first wave, we have no any option of remdesivir in our setup, but in second wave, we have the option of remdesivir. And also I have very good experience of the remdesivir. So many patients are recovered very soon after administering the remdesivir. My one question is for the Dhiren sir, that as you told that there is no role of anticoagulant in mild cases, but I seen so many patients who are having the CT score of 8 to 10. Their SpO2 is maintaining normal, but their D-dimer level is very high. It is around more than 2 to 3 times of the normal level. In that case, I am generally using the anticoagulant, but what's your view?
Yeah, I also used anticoagulant in those cases where CT score is high, where you tend to give some steroids and anticoagulant. So my rule used to be like, if patient is requiring steroids, I used to give anticoagulant. But it's a recent studies based on the Delta wave. They recommended that in mild to moderate, actually you don't need, means the role of anticoagulant has decreased. And what Dr. Dalmia said is right, that if very high risk chances of means a severe disease or risk of thrombosis or event of thrombosis, demonstrated event of thrombosis, then of course you tend to be very aggressive. But I agree with you that some of our patients were D-dimer, as last speaker said, there is no relation with the D-dimer. Means at times D-dimer can be high and there was no thrombosis. D-dimer was normal and there was intense thrombosis. So there was no very clear-cut relation. But in some of the patients where D-dimer used to be very high, and these patients land up in acute thrombotic event. So having said that, problem, the major problem what I found in mild cases, or you can say not severely hypoxic, but of course CT scan changes are there and patient is little bit towards hypoxemia and persistence of fever. In these patients, the D-dimer, if we try to get an OPD level, then because of the duration they keep in fridge or they don't do testing within 2 hours, that was the reason for high D-dimer rather than actual high D-dimer. That was a major problem which I found in OPD patients or samples collected from home.
Thank you. Dr. Urmil Tripathi, the president of OBG Society of Gwalior is with us. Dr. Tripathi, do you have any question?
I see 50% of the population is female population, and of course a certain percentage of them is pregnant at any point of time. So since this has not been touched upon, I would like to just tell about my experience of the first and second wave. In the first, you see, pregnancy is a comparatively immunocompromised state, theoretically. But practically what we see, they are young women who are healthy. And most of them do not have comorbidities of middle and higher age groups. So, I mean, they are able to walk over this COVID infection, some of them who have had, very well. And in due course of time, they would get well. This was our experience in the first wave. Patients would come with the infection. If they come positive, we would shift them to the COVID facility where, as you said, Dr. Nilima was the head and she was managing very well along with us. But in the second wave, what we found is we had certain cases where if the patient had pulmonary infection, I mean, severe COVID affliction, they would not get well. Although we didn't get many cases, but 2 or 3 of them, if they were preterm, we thought that COVID would be in control like it has been in control earlier. But then we had 3 deaths. So we changed our policy after this first index case that even if she is preterm, we would not like to prolong her pregnancy. If she is moderately infected with, moderate symptoms of COVID and with pulmonary affliction, we would go for termination of pregnancy. And then we could save many more patients. So this is what I had to say. Otherwise, the discussion is complete.
Any this thing in management, any change in management, giving remdesivir and other things?
No, first wave, as she said, we didn't have.
Second wave and now in the recent wave, Dr. Dhiren also I would like to have your comment on this.
One point only.
Doesn't matter. It has to be carried out for the infection first. Life is important. And then those who received in the, later on, no side effects or no effects on the baby have been observed.
Thank
so
you.
they can
Dr.
carry on
Dhiren,
with the usual.
your
So 2
comments,
points.
please.
One is that D-dimer. In pregnancy, in third trimester, second trimester, highest level of D dimer is much more than the normal female. One. Secondly, as per the age, the D dimer is like if somebody is having 88-year-old, so 88 into 10. So 880 will be the D dimer, means, you know, an optimal level of not 0.5 or not 500, right? So that point I want to elaborate. And of course, so we always keep that D dimer is one of the factors, but sampling and collection as well as storage is very important to analyze just D dimer. I've seen few of the patients who got admitted. One of my patient known to in Lucknow was admitted, was given remdesivir and steroid just because his D dimer was 3 times, and the rest there was no problem at all. So I mean to say, probably as a clinician, we should not lose our common sense, even if we are even if we are analyzing the data. So number at times, creates shock waves, not among patients, but among doctors also. So our anxiety leads to overtreatment.
Thank you. Doctor, I could see Dr. Vrindha Joshi here. Yeah. Doctor.
Can I just comment? Can I comment just quickly on Dr. Tripathi's point? I think
please.
In one of my slides, I highlighted now the pregnant women being affected more, young pregnant. So I think it was there from UK experience. In our local experiences, yes, we had some mother who were pregnant and got COVID, and then we got a preterm babies, and they require really intensive care to that extent. So I think they are quite vulnerable group, and I think your point is very valid, to deliver the baby by hook and crook and save the mother. They all got saved, but we need to intervene at that point rather than prolonging the pregnancy.
But sir, can I ask one question from Dr. Alok?
Yes, sir.
Please.
Sir, sir, what is your experience in UK? Is it there is an increase in incidence of COVID pneumonia and leading to admission in pediatric age group in UK hospital, or it is just because number of infections are high, so many patients had COVID and had some disease, so they got admitted, so that's why numbers are high?
So numbers are not high in the hospital. If you remember my slide, they are significantly less compared to first peak and second peak. So we are not hitting those numbers in the hospital setup, but they're all in community because we are doing a lot more screening, testing, and they are not unwell people, children, and but we are seeing more. And there's one reason why we are seeing more in young population is they are the unvaccinated one. Either they got one dose or second dose, and that's why the data was very clear in second peak. Okay, the vulnerable people had at least COVID, because they are the first one who got vaccinated compared to rest of the population. So that was very convincing data in the second peak, and that still remains true. Okay, because of vaccination, you're preventing a lot of people. The number may be high because Omnicron is very contagious, but that not resulting into illness enough to come to hospital and admitted. And I said about pediatric, we may have 5 to 10% children on the ward, but not necessarily they are, I think, because of COVID. Some of them, they are picked up, I think, COVID positive because we are doing point of care testing at the front door, but they didn't present with COVID illness or pneumonia. So your point is correct in terms of we are not seeing a lot of COVID pneumonia.
Can I take it further?
Good evening, sir.
Yeah, please.
So sorry, there was some connectivity problem. Sir, I'd like to ask
Dr. Nilima Tandon. Yeah.
Yes, sir. In last COVID second wave, after a few days, we were started doing alternative BiPAP and HFNC ventilation trials. So whether Sir Dhiren sir has found any benefit of doing alternative BiPAP or HFNC, or doing only BiPAP or HFNC will do the same?
I think whatever suits the patient, and it's a tolerability that is you most, and availability in second wave means if you ask me, whatsoever was available, we applied, and means we didn't find any difference between NIV and HFNC. But of course, HFNC is much more better tolerable. Tolerability of HFNC is much better than NIV.
Sir, I'm asking about an alternative therapy of alternative BiPAP and alternative
No, I don't
SNS.
think, because when you apply HFNC, you put an adhesive, then you take away the adhesive, and then you apply NIV, or you on the tube. If you try to apply NIV, means you're making unnecessary changes and making the patient uncomfortable, and during that change, you can induce hypoxemia. These patients are very vulnerable. You touch them, you make them awake, you make them irritable, and they desaturate like anything. Leave aside transportation. Many of the patients died when they were getting transported to Delhi. So everybody knows. So everywhere management is same. Over the time, everybody knew that there are just 3 modalities and everything is available in Gwalior itself. So I mean to say, don't try to change the modality NIV and HFNC. Alternatively, say every 6 hours or 12 hours, that is going to harm the patient.
Okay. Also, I'd like to ask one thing also, that as we are not having any proning beds available in our area, so we are doing maximum lateral approaches in mechanically ventilation patients, because prone ventilation we were doing in all other patients, but in mechanically ventilated patients, proning is not possible with us. So we are doing maximum lateral. And,
you can. Yes, I got the idea. In proning beds are, is each bed crore is in 1 crore to 2 crore. No, it's not available in India, right? And that occupies almost, it's a huge bed. So probably it's a useless thing. So you can prone, but you need good number of staff if you're going to prone 80 or 110 kg men. So that is a major problem, and monitoring is very important, and they are very risky. So that is the problem, not the bed, not non-availability of bed.
Sir, on alternative to proning, we started doing
now in conscious patient, it's very easy. I used to enter in ICU, so 90% patients used to be prone, right? But on a ventilated, intubated, sedated, paralyzed, proning is little bit difficult. The procedure is little bit tricky. So you can try if you've got number of staff, and number of staff is the major problem. During proning, especially a sedated, paralyzed or intubated patient, you need lot of staff, and that is a risky time. So if you're able to prone it, then it is not of a major problem. But again, you cannot prone for 3 days, 5 days. You have to again supine it for another 18 hours or 24 hours. So that is a risky thing. So in conscious patient, proning is much easier, and everybody tried that conscious proning in most of the COVID patients.
Thank you, Dr. And one question for Dr. Our ENT specialist, Dr. Ravindra Bansal. Do you have any question for the panel or from our experts? Dr. Ravindra Bansal.
So I just want to know the effect of Omicron on the immune system in comparison to Delta virus.
Omicron doesn't induces TMRSS protein, so doesn't lead to synechia formation. That's why pathogenesis for the lung that is needed is not there. That's why pneumonia component is missing. There are 2-3 more factors. That's why it is mainly in upper respiratory tract infection, like an influenza, where wet cough is there. So wet cough is different from a dry cough, which used to be in Delta. So it gets inside like a pinocytosis, and it doesn't lead to synechia. It doesn't fuses the cells with each other.
Syncytium formation.
Syncytium formation.
Syncytium.
So, otherwise, Omicron is like an influenza with the shield of Omicron COVID virus. So something like it looks like more like an influenza virus.
Dr. Ravindra is a ENT specialist, so he has seen a lot of mucormycosis cases, and that was due to the lack of decreased immunity. And he is asking this question because he has faced them using last time.
Dr. Ravindra, in fact, nobody knows the immune, how this Omicron is working, or how the immune function will work, and something like that. Even I think Omicron also doesn't know that how he is going to proceed further. I mean to say, this is the past three ways we have seen. So probably it is full of surprises. It is going to be full of surprises. How these patients are going to behave post-COVIDly? I think Dr. Alok can give us an idea. Are they getting MISC? Are those patients, because they are 1 month ahead to us, are they getting post-COVID syndromes, especially in pediatric age group? Are they getting some side effects, which we have found in wave 2 and wave 1?
Long COVID.
I can chip in actually. Dhiren, in terms of first question, I think you were asking about the respiratory. We are not seeing much respiratory, but in terms of pediatric, we were really fearing about the two pandemics, the winter virus, RSV virus, and the COVID. But RSV is really significantly less compared to normal winters. But we have seen rhinovirus a lot more compared to, and hardly any COVID pneumonia. And the last 2 weeks ago, I was on the ward actually, and we've seen one baby with RSV positive and COVID positive. But baby was not behaving like COVID, more like RSV kind of virus, that kind of picture. So that's really one important thing. In terms of COVID, post-COVID, and long-term, we have children, I think, who has got symptoms, ongoing symptoms of post-viral fatigue syndrome kind of picture. So that's something we are seeing, not mycosis and thing. And second thing really, which we hardly talk about in our setting is emotional well-being. A lot of people, I think adult and children, they got a lot of post-COVID emotional issues, which is something I think worth acknowledging in this forum. A lot of people can have an emotional impact out of COVID, and that we don't know enough whether there's something long-term COVID issues or there's something just happened because what's happening in the world. But there's a lot of issue around the emotional well-being, and we have a high number of suicides as well, where young people have committed suicide or even elderly.
Psychiatric problems.
Psychiatric.
Okay. One question, Dr. Alok, out of your experience and what UK has experienced, is this the beginning of end of COVID pandemic? Because a lot of news are there that this is the beginning of end of COVID pandemic, and with this mild virus, it's a nature's way.
I think that's the way the history of any viruses. When they come, they are very virulent, and we don't have anything to fight with them. Then when they start multiplying and cloning and changing like a variants, they lose their virulence, but they become more contagious. It may become like a common cold. So when we meet and greet, we get from each other, but then we don't need to become unwell. And that's most likely the way we are feeling about with Omicron, because there's many thousands of people out in community who are either asymptomatic or has a mild symptoms of cold or body ache or fever, but they're not being unwell, maybe because of vaccination, but at the same time, herd immunity, I think is an important role to play, plus virus losing its potency.
Yeah, since I just want to add one point. I totally agree. This virus is, more immunogenic than pathogenic. So it induces immunity much more than other previous two waves. Secondly, the sera of this virus infected patient, of course, is going to inhibit Omicron and as expected, but also can inhibit Delta 4 times. So I mean to say, but problem is only that you can trust, okay, this Omicron, looking at past 2 weeks and looking at Dr. Alok's data, but we cannot trust the virus mutations. So it means it is full of surprises, and this is a very long virus RNA in the Omicron. So we don't know. It looks like for past 1.5 years, from the original strain, it was mutating in either in some animal or in some HIV infected human. So we don't know what is being cooked up in places like China, places like South Africa, where a lot of immunocompromised patients are there. So probably we may be very, sure from our side and confident, but we are not sure from virus side.
I think time is over. I will request Dr. Navneet Agarwal to please give vote of thanks. And Dr. Prashant, if you are there, Dr. Prashant, if you have any question, Dr. Laharia, Secretary of IMA Gwalior. Okay, Dr. Navneet, please quick, because there is a sign that it is getting over. Our time is over.
Thank you, sir. Thank you. In fact, it was a wonderful discussion that no one was seeing the watch. So the discussion was going on so smoothly. So thank you, sir. On behalf of Gwalior IMA branch, I wish to thank all the learned speakers. My sincere thanks to Dr. Sushila Kataria, who has given us the guidelines to differentiate between the grades, to differentiate a patient between mild, moderate, and severe, and how to plan the treatment. So thank you, Dr. Sushila. And in fact, like it is good to see you almost after 2 decades. In fact, we were together in the post-graduation in Rohtak. We did MD together, me and Dr. Sushila, but in the same unit in Rohtak doing our MD. So it's great to see you after 2 decades, Dr. Sushila, and thank you for guiding us. My sincere thanks to Dr. Dhiren Gupta, sir, who has been a great academician, great teacher, and in fact, he has been my teacher during my undergraduation in Gwalior. He was our RMO, and thank you, sir, for giving us the evidence-based guidelines. And I'm sure we all will agree, Dr. Dhiren has been a helping hand in Delhi during COVID, and in fact, before that, for helping all patients of Gwalior for the getting beds or for any guidelines, and he has been guiding us for last 2 years during the about the COVID pandemic, and we are always asking him about the COVID guidelines and the treatment protocols. And so, thank you, sir, for the kind help. You have been always there. My sincere thanks to Dr. Alok Gupta, sir, who has given the overview of world COVID and guiding us with his experience of this Omicron COVID, because like they are almost 1 or 2 months earlier, they have seen this pandemic or the wave of this pandemic. So thank you, sir, for enlightening us with your experience, guiding us that what to do, what not to do, what to fear, what not to fear. So thank you, all the learned speakers. My sincere thanks to the moderators, Dr. Basin, sir, Dr. Abid, for nicely conducting the program, moderating the program, and taking the questions of all the audience and covering all the points related to Omicron, because like there are so many controversies, so many points to, and everyone is in doubt what to do, what not to do. Patient will get admitted or not to get admitted, what to treat, what not to treat. So thank you, sir. Thank you, our all panelists, Dr. Manish Gupta, Dr. Ajay Gaur, sir, Dr. Ulmitra Padati, Dr. Ravindra Bansal, Dr. Anupam Thakur, Dr. Ravi Dalmia, for giving your valuable experiences, sharing your experiences regarding the COVID management, Dr. Manish Sharma. And my sincere thanks to our president, IMA Gwalior branch, Dr. Priyambada Vasim, who has taken so many pains for updating the members of Gwalior IMA, for updating, keeping ourselves abreast with the latest in whatever the field. So those organizing the CMEs regularly and updating us all about these all the updates in the medical field. And my sincere thanks to all the members who has been there on the Sunday evening, this rainy, chilly winter evening, and enjoying the discussion. So thank you once and all for every member, and my sincere thanks to the Ajanta Pharma for organizing this Zoom meeting. Thank you, everyone.
Thank you all. And in this chilly winter, instead of Rajai, we are here to to listen to what new COVID wave is going to be and how to manage. Thank you, Dr. Dhiren, Dr. Alok, and Dr. Kataria, and everybody on board. Thank you.
And all are cordially invited for a dinner at their respective homes.
we were expecting that you will send some Swiggy vouchers.
So next time we will have a physical meeting.
Good night to everyone. And
thank you, sir. Good night, sir.
Good night, Alok, sir. Thank you very much for your input.
Nice seeing you, Dhiren.
Thank you.
Thanks to all. Thank you so much.
Thank you.
Thank you, Dr. Alok. Thank you, everyone. Bye-bye. Good night.
Bye-bye. Bye. Good night.
Bye. Bye, Naku.